Welcome to the Walrus Talks at Home Mental Health, presented by Brain Canada. I'm Jennifer Hollett. I'm the Executive Director of the Walrus, and we're thrilled to be joining you online, bringing people together across the country in conversation. I'd like to start by acknowledging the land that I'm on. I'm in downtown Toronto right now, Toronto. I come to you from the traditional territory of the Mississaugas of the Credit, the Anishinaabeg, the Haudenosaunee, and the Wendat peoples. We encourage you to take a moment to reflect on the land that you're on right now, wherever you're joining us from tonight. A bit about the Walrus. The Walrus started 18 years ago, really as an optimistic project to tell the stories of Canada and to foster conversation. And we do this in a number of ways, through our fact-based journalism in the print edition of the Walrus, but also online at thewalrus.ca, through our podcast, The Conversation Piece, and through our public event series, The Walrus Talks, which is now The Walrus Talks at Home, The Walrus Talks in my home, The Walrus Talks in your home. And this work is powered by our donors, our partners, and our sponsors. So thank you all for being here, and to Brain Canada for making this event possible. To start tonight's conversation, please welcome Brain Canada's President and CEO, Viviane Poupon.
Hello. What a pleasure to be here with you tonight. On behalf of Brain Canada, I'd like to welcome you to this important conversation on mental health. Thank you to all those tuning in from across the country and beyond, to our incredible speakers who've given their time to take part in this conversation, and to the Walrus for organizing the event. It has been a difficult and a challenging year, with so many of us confined to our homes or working on the front lines as essential service providers. Some of us have feared for health and the health of our loved ones. We have experienced economic hardship and social isolation. Collectively, our mental health and well-being has suffered. And indeed, the COVID crisis has underlined a critical need for enhanced mental health research and care. Today, more than 60% of Canadians who struggle with mental illness and 40% of all Canadians say their health has declined since the onset of the pandemic. We are at a critical juncture, and the time to act is now. The next wave of this pandemic is the mental health crisis. And so we must ensure our healthcare system is equipped to meet the rising demand for mental health resources, services, and treatment options. To make advances in this space, we need to utilize new and emerging knowledge, and we need to find ways to implement it in order to achieve meaningful outcomes for all Canadians. Brain Canada is well placed to play a leading role in this space. As a national charitable organization founded over 20 years ago, we strive to better understand the brain in health and in illness, and we aim to improve lives and have a positive impact on society. Last month, we issued a call for applications for a new 4 million research competition in partnership with Bell Livestock to accelerate Canadian brain research while helping to address the impact of COVID-19 on mental health care. I am proud that through the Canada Brain Research Fund, an innovative partnership between the government of Canada and Brain Canada, we have started this far-reaching new mental health initiative. And we will launch over the course of 2021 new programs with new partners to develop and implement effective prevention and intervention strategies in diverse settings related to mental health care for Canadians. As a research convener, we want to provide opportunities and build together a community of people who want to improve or collecting brain health. Understanding the brain in health and in illness does not happen in isolation. It needs a community, it needs you. So thank you again, and we hope the discussion is meaningful for you.
Thank you, Viviane. Tonight's conversation on mental health is really an important one, especially right now in a pandemic. It's something a lot of us are thinking about and trying to navigate. This evening, we'll hear from 4 leaders sharing their perspectives on the stigma of mental health and the effects of COVID-19 on our collective mental well-being. Here's how it works. Each speaker has 5 minutes. Then once your head is full of new ideas, we'll have a moderated Q&A session with the speakers and you, our audience at home. Tonight, we'll be hearing from health reporter at the Globe and Mail, Wency Leung, neurosurgeon Dr. Andres Lozano, network representative at jack.org, Sope Owoaje, and author of So-Called Normal, a memoir of family, depression, and resilience, Mark Henick. Thank you so much for joining us. Over to the speakers.
Hi, my name is Wency Leung. I'm a health reporter with the Globe and Mail. Remember what loneliness felt like before the pandemic? For me, it was the occasional pangs of longing for company whenever I went traveling alone for work. Now it's the craving for even a superficial chat with a stranger when I'm stuck alone in my home office. If many Canadians were lonely before the pandemic, even more have now joined those ranks. The thing is, loneliness isn't benign. It hurts our physical health. It hurts our mental health. It can even kill us or take years off our lives. A few years back, I noticed a cluster of studies crossing my desk that showed loneliness increases people's risk of a range of illnesses, from cardiovascular disease and cancer to depression and dementia. One study in particular, an oft-cited 2015 meta-analysis from researchers at Brigham Young University, showed loneliness and social isolation are as deadly as very well-established health risk factors, such as obesity, smoking, and lack of physical activity. So why is loneliness so toxic? I started seeking out experts in this relatively new field of loneliness research to find answers. As it turns out, the pandemic has highlighted some of the potential mechanisms. First of all, interacting with others is intrinsically rewarding. Take that away, and it's no surprise it can negatively affect your mood. Social interaction is also perhaps one of the most cognitively stimulating things we can do. Without the mental exercise of keeping track of who's who and who's doing what, I'm hearing from doctors and nurses that people who already have dementia are experiencing more rapid cognitive decline. Second, other people give us important social cues. They help provide us with motivation, and they take care of us when we're sick. Without them, hospital ERs are now seeing a rise in patients, particularly older adults who are forgetting or neglecting to take their medications, becoming emaciated due to lack of appetite, and putting off seeking care for symptoms like heart attack or stroke. By the time they do show up at hospital, their prognosis is much worse. If while in lockdown you found yourself putting off showering, eating whatever's at hand instead of making yourself proper meals, or just struggling to motivate yourself to get out of bed, you may have a sense of what I'm talking about. If there's no one around to care whether you do these things or not, it can be easy to neglect self-care. But there are hypotheses that the harms of loneliness go even deeper and are tied to inflammation, our immune system's response to injury and pathogens. Inflammation is beneficial when it's helping our bodies heal or fight off illness. But when it's chronic, inflammation can actually damage our health. Chronic inflammation has been linked to a host of illnesses, including depression. The other piece of the puzzle might be the stress itself of being lonely. Chronic stress is tied to elevated levels of the stress hormone cortisol, which affects regions of the brain involved in emotion as well as cognitive function. So stress may also affect our sleep, and lack of quality sleep can also be detrimental to our mood and our ability to focus and concentrate. The good news is there are ways we might be able to cure loneliness, or at least mitigate its ill effects. Because there's this idea that inflammation plays a key role, researchers are looking into whether anti-inflammatory medications can reduce some of the harms of loneliness. If this bears fruit, we may see a day when doctors prescribe Advil as part of their treatment of lonely people. Another idea is to engage in pro-social activities. So simply going out and meeting other people isn't very effective. At any rate, we can't gather right now anyway. But if you just throw a lonely person into a party, there's a real risk they could feel even more alienated and lonely if they don't make any meaningful connections. But say if you do some volunteering or participate in a group hobby, which can be done virtually, then you engage with other people for a common purpose without the pressure of making friends. There also appears to be benefits to simply opening up about your loneliness. The more we destigmatize it, and the more we learn there are others out there feeling lonely too, that can make you feel, well, less alone. Finally, if there's one thing you can do today, it's to pick up the phone. Call a parent, call your socially isolated aunt or uncle or cousin or friend. Ultimately, the solution to loneliness is letting others know you care about them and knowing they care about you back. Thank you.
Good evening. I'm Andres Lozano. I'm a professor of neurosurgery at the University of Toronto, and I work at Toronto Western Hospital, and I'll be speaking about deep brain stimulation for treatment-resistant depression. Some depression facts first. So depression occurs in persons of all genders, ages, and background. It's more common in women than in men, and depression is one of the leading causes of disability worldwide. And in fact, it contributes to the 800,000 or so suicides that occur worldwide every year. Now, depression can, of course, be treated, and there are medications. There's talk therapy. There's even electroconvulsive therapy. But despite that, there are some patients in the order of 10 to 20% of depression that are still disabled despite all these available treatments. These patients are said to have treatment-resistant depression, and these are the patients that we're interested in, treating these patients that have failed all other conventional therapies. Now, we have done some studies on brain activity in depression, and we've discovered that in patients with depression, there are striking abnormalities in the brain activity. Specifically, we can do a PET scan and measure the brain activity, and the red areas are areas that are overactive compared to control, and the blue areas are areas that are underactive. And what we've discovered is that in patients with severe depression, the areas of the brain that are involved in sadness are on overdrive. So these are seen in red and in cingulate area 25, CG25. So it's as if the thermostat in your home is set to 50 degrees Celsius instead of 20 degrees, and it's stuck there. There's no way to move it. It's always stuck at this high level. So the sadness area is on overdrive, and other areas of the brain are underperforming. The areas in blue, these are the areas that are involved in motivation and drive. And this is why patients with depression are withdrawn and lack motivation and drive, because these areas of the brain are shut down. So what we want to do is use deep brain stimulation to implant electrodes in these areas, specifically in area 25, this overactive area, to see if we can turn it down and to see whether that in turn leads to improvement in the depression in our patients. So this is done by implanting electrodes in the brain and hooking up the electrodes to a pacemaker. And we're able, with a remote control, to regulate how much current is delivered to the brain. And the current is delivered 24/7. And so those batteries last about 5 years, and we're able to then change the batteries if needed. What we've discovered is by implanting electrodes in area 25 is that indeed one can turn down this area. One can turn down the dimmer switch or the thermostat, if you like, from 50 degrees back down to 20 degrees. And so we see in the top that before surgery, area 25 was red, and after the surgery, we see it turns to blue, and that means that we're able to turn down the activity in this area. And then the areas of the brain that were previously shut down in blue on the top of the screen now come back online. They turn to red, and this indicates that they now start working once again. So we're able to reverse the abnormalities in the brain circuitry function in the brain. This is associated with improvements in their depression. So we've now looked at over 170 patients worldwide that have received this procedure, patients with severe depression. And what we see is that after 6 months, about 30% of them are better. After a year, also about 40% are better. And after 2 years, about 50% of them are better. And we consider them to be better if they've improved by at least 50% on the depression scale. So it looks like after 1 or 2 years, you get about a 50% improvement in the depression in these patients with severe depression that have failed all other treatments. So in conclusion then, this procedure of implanting DBS electrodes in the brain in patients with depression appears to be safe. One can adjust the activity of the brain in the circuits involved in depression using electricity. It appears that DBS is effective in the long run. We know that the location of where we put these electrodes and how much electricity we deliver is important. We also know that choosing correct patients is also very important. Where we are now is that this procedure needs to be evaluated by the regulatory bodies, and they have to determine whether it's safe and effective and whether they think there's enough evidence to approve it as a therapy. And if so, it may mean that we now have a new therapy to treat these patients who have severe depression and have failed all other conventional therapies. Thank you very much for your attention.
Hello, I'm Sope Owoaje. I'm a nurse, I'm a mental health advocate, and I'm a network representative for Jack.org. When we talk about mental health, it is crucial to understand how fundamental it is to our overall well-being, and thus should be treated as such. In any given year, 1 in 5 people will experience mental health challenges, and only 1 in 3 will seek the appropriate services. Suicide is the #1 health-related cause of death for young people in Canada, and in the North, the state of mental health care and suicide rates are frightening, and over 8,000 youth are expected to struggle with their mental health at some point. Mental health is like physical health, but involves our thoughts, feelings, and behaviors, and can be impacted by various factors such as biology and genetics, individual environment, culture, and societal structures. One of the greatest stigmas is that mental health and mental illnesses are the same. Mental illnesses are clusters of symptoms that can affect our mental health. 1 in 5 people may experience mental health challenges, but 5 in 5 of us have mental health. Stigmatization of mental health has always been present, but even more so for BIPOC, Black, Indigenous people of color communities who often face significant barriers. While health conditions do not discriminate, people from some demographics often have difficulties accessing mental health treatment and services, compounding the struggles to spread awareness and access better health care. To understand the plight of BIPOC mental health, it's crucial to take a deeper look at the obstacles that keep from seeking help. Stigma. Stigma can be cultural. Various groups of people view mental health differently. As a Black woman and growing up in an African household, mental health was not something often discussed. When in distress, you could often hear there are bigger problems in the world in relation to world hunger or homelessness. We are meant to be strong and resilient, and mental health challenges can be seen as a form of weakness. Due to colonization and standing colonial structures, struggle has become such a natural part of BIPOC lives due to slavery, constant discrimination, residential school, that anxiety or depression may not be viewed as health issues that warrant professional help. Awareness plays a huge role in the way mental health is addressed. Many people from BIPOC backgrounds may be distrustful of the system. Raising awareness and providing appropriate information can help address the disparities in the mental health field. Up to this point, accessing mental health services has been a privilege and not a right, leaving many individuals without essential support. In some provinces and territories, psychiatrists are covered by provincial or territorial health insurance, but psychologists, psychotherapists, and counselors are not. In other provinces and territories, therapy is only covered if it's through a hospital or mental health institution. That means that most people are left paying out of pocket. Fortunately, there are a number of private mental health clinics across the country offering services that are either free, covered by private insurance, or adjustable to individual income, but they're not always the easiest to find. In the North specifically, there are significantly less mental health services available. The services available have long wait times, transient support, and may not be in Indigenous language. Individuals that require extensive mental health services are often sent out of territory to receive treatment that may not be culturally competent or safe. Language is not always translatable. Trauma and feelings may not always be translatable. It's important for individuals to have access to services that provide competent support. Perhaps the biggest challenge for BIPOC is the prevalence of discrimination and biases from mental health care providers. Sometimes these biases are explicit, other times not so much. As a result, many people from BIPOC communities are less likely to receive treatment because many providers are not trained in culturally competent care. For example, in Nunavut, counselors who come up to work are not always versed in the colonized history of the territory and may have preconceived biases. This can be dangerous as communities are healing from recent and intergenerational traumas. The mental health system is complex. Many people are unaware of what programs are available for them. Once policymakers and those behind the mental health system have this understanding of their roles and responsibility in curbing disparities through destigmatizing mental health through mental health education, increasing accessibility, improving the social determinants of health, and offering culturally competent care, they can provide better mental health care for all, including BIPOC communities. Thank you.
Hi, I'm Mark Henick. As we share this short moment together, I'd like to reflect with you on one simple question, and that is, what do we do now? We've been through so much. We're in so much. So what comes next? Where do we go from here? I've asked myself this question a lot over the last year of the COVID-19 pandemic, yes, but it's also been a central preoccupation for much of my life. For more than 20 years, I lived with major depressive disorder. And from that experience, I'm the grateful recipient of many important gifts. I'd like to share two of these gifts with you today, because if you want to learn something about processing restrictive isolation, then depression happens to be an excellent teacher. One gift of my depression was a fully immersive lesson in how to sit with suffering. At first, I reacted to the internal and external isolation of my depression with confusion and denial. Why did I have to win this particular lottery? I don't want to carry this. And the most dreaded of all, it's not supposed to be this way. Embedded in that early judgment was the idea that there is another way, that some easier life that others had access to was just over the horizon. If only I could get what I wanted. If only it wasn't so hard. If only. Then came the idea for me to escape, followed swiftly by the expressions and then the attempts to do so. This was the phase in which, rather than release my ego and see what happens, see what it becomes, I thought I had the choice to opt out of the game entirely. Then much later, with a lot of work, came acceptance. We can't control the ocean, but we can become stronger swimmers. In letting go of the desire to control other people's minds, ironically, it gave me back control over my own mind. It's not supposed to be this way gradually became, it can be any way, and I'll be okay. The other gift from my depression was a front row seat to the impermanence of the moment. Those moments, this moment, every moment. Inevitably, the snow will fall and the sun will rise. People you love will die and new love will take birth. Memories fade and new ones are made. This is the natural cycle, the seasons of our lives. And when we cling, when the stickiness of our fearful judging mind won't let go and greet the new day, that's when we suffer. When the world has other plans, when our intentions encounter obstacles, we can't get past that old refrain that it's not supposed to be this way. But it is this way. Just because you don't want it to be, or didn't anticipate it to be, or are tired of a global pandemic, that doesn't make it go away. Going back to the normal that never was won't take away your suffering. It'll just give you a few more ways to run from it. It's okay to be tired. It's okay to be angry and bored and frustrated and lonely. This is hard. But we can still do hard things. Hard choices and policies might still in fact be necessary, and perhaps for longer than we personally might like, in order to protect people more vulnerable than you. The pain of my frustrated desires, however important those desires might be to me personally, and I'm the center of my own universe after all, as you are all too. They're worth sparing even a few others the very real physical and psychological pain of trauma and grief. Circumstances can be painful, that's reality. But pain doesn't have to lead to suffering. My depression taught me that. And it also taught me that regardless of the circumstance, you have two choices in life, to grow or to die. Growth looks differently for everyone. It sometimes includes injury and it always requires rest. But biological systems that wall themselves off, that become impermeable to the processes that regulate and evolve them, those systems are the ones that suffer and die. Cognitive rigidity creates psychological sepsis. So whether we're through the worst of this pandemic or we have more waves to come, we each need to ask ourselves if we're becoming stronger swimmers. We can cling to the rocks of the way things were, create more friction, more tension, more anger. Or we can ask, each of us in our own way, what this moment in history can teach us. Not complex, fanciful theories about society or generations or politics, but about you, your habits, your mind, your heart. When we someday reach the post-traumatic period of this post-pandemic, and this too shall pass, what will you have become? Will you have been a victim of the circumstance? Or will you have grown? In this moment, and in every moment, that choice is always yours. So, What will you do now? Thank you.
Thank you so much to our speakers, Wency Leung, Dr. Andres Lozano, Sope Owoaje, and Mark Henick. And thank you to our audience. Taking a look, we have audience members registered from all over: Vancouver, Edmonton, St. John, as well as Uruguay, the Philippines, Mexico, from all over. Great to see you. We encourage you joining us from home to share this conversation on social media. You can tag us at The Walrus on all the major social media platforms, and the hashtag is #Walrus Talks. Now for our Q&A session. We're doing something special tonight. We have 6 copies of Mark Henick's memoir, So-Called Normal, to give away. If you participate in the chat, it could be a comment, it could be a question, you will be considered, and we will be picking 6 people and notifying the winners after tonight's event. Our moderator this evening is Toronto Star mental health reporter Nadine Yousif. Nadine, thank you so much for joining us. Over to you.
Oh, thank you so much, Jennifer, for having me. I just want to thank the Walrus for the opportunity to moderate today's event, especially after hearing really thoughtful and engaging talks from our speakers this evening. Thank you again to Wency and Dr. Lozano, Sope, and Mark. I know I have a lot of questions, and our audience members probably do as well. So we are going to start our Q&A session. If you have a question, you can ask it in the Zoom chat box below. And yeah, without further ado, we'll get started. I have a question. My first question is for Wency. Wency, you spoke about loneliness, and I think loneliness is something that most of us have experienced in one way or another in the last year, dealing with social isolation and just, the pandemic. And I do know that people have largely resorted to virtual means to connect with loved ones as the virus continues to keep us physically distanced from one another. And I was curious if there's research that suggests whether this virtual connection alone can alleviate the ill effects of loneliness that you sort of spoke about, or if there's something intrinsically valuable in physical closeness that we just can't replicate until maybe we can really see each other again.
Yeah, that's a great question, Nadine. And I haven't seen a lot of research in terms of like whether the virtual means of communications can replicate the face-to-face, but there is a lot of research about what we're missing with the face-to-face and like the in-person communication, especially when it comes to human touch. There's a lot of research into just how important touch is to even human development, neurodevelopment, and so we are missing that huge piece. But I think like in the absence of that, it really is what I had wanted to say is it's so important to just pick up the phone and call. One of the remedies for loneliness, really, I mean, the ultimate remedy for loneliness is to show other people that you care for them and that you're cared for back. So yeah, I do think in the absence of face-to-face, this is kind of what we need to do.
Yeah, absolutely. I mean, social distancing is important so that we can keep each other safe. And I am grateful that we have all these sort of means to connect regardless of that, and even to be able to do this today. So yeah, thank you so much for your answer, Wency. My next question is actually for Dr. Lozano. You spoke about treatment options for people who are suffering with depression, where they've tried every other sort of treatment and it didn't work, and this is sort of the new frontier, so to speak. I'm imagining there's quite a number of people who would probably like to have the opportunity to be able to try a procedure like this and see if it would work for them. So I'm wondering where you are in your research, and what is the timeline before we can see a procedure like this available as a treatment option for the general population in Canada?
Well, thank you for your question. So indeed, we are looking at treating people that are the most extremely refractory patients, the people that are the most ill of the ill, people that are suicidal, people who, whose life is threatened by their depression, who've had chronic depression for years and years, in many cases, decades, who've tried multiple drugs, who've tried psychiatric therapy, even electroconvulsive therapy. So really, you must have tried all of these things first to be eligible to an experimental therapy. So this is still considered an investigational therapy in that we still don't know enough about how safe and effective it is. So it looks like it might be safe. It seems to be quite safe. We do this type of DBS procedure in many other conditions like Parkinson's, for example. So it looks like it's quite safe. The issue is how effective is it and how long does the benefit last? If you're going to go through an operation, you want to know that it has enduring benefits. So we're still at a research stage where we are now presenting this kind of data to the regulatory agencies, and they have to assess it and decide whether there is sufficient evidence that it's safe and effective to allow more widespread and generalized use. But for the time being, it's still considered an investigational procedure.
Right, right. Just still really interesting to know that, we're sort of, there's a lot of progress that's being done in terms of, treatment for people with mental illness, and definitely a long way to go. So yeah, thank you so much for the research that you're doing and also for answering my question. I do have some questions from the audience as well. So this question is from Allison, and I will ask it to Mark if that was okay. Mark, Allison is asking, what would you recommend to people in deep depression right now, I guess, in terms of just words to help them or anything of the sort? What would you sort of recommend if somebody's finding themselves in deep depression right now?
I think what I would always try to recommend to myself anyway, because I think we need to practice what we preach, is to be gentle with yourself, that this is hard. I think for me, again, one of the worst symptoms of my own depression was this critical mind, this hyper-judgmentalism, that I should be getting better, I should get out of bed, I should all over myself, until I just ended up feeling worse and worse, and it wasn't helpful. So be gentle with yourself, permit yourself to feel your feelings fully, even though it's hard. But also, I think the second half of this is be willing to push yourself as well, to do things that are hard, because depression has a lot of habitual pieces to it that aren't serving you. We tend to believe everything we think, that we can't get out of bed, for example. And that may not necessarily be true. We might fully believe it, but even if the best we can do that day is drag ourselves out of bed to get a shower, then at least that's a little bit better than sliding back. So do what you can, meet yourself where you are, and be gentle with yourself. I think that's, we could all stand to do that, especially those who are in the deepest pit of depression.
Yeah, absolutely. A lot of the times we forget to be kind to ourselves. So yeah, I do appreciate your comments, Mark. Thank you. I do have another question from the audience. This is from Elaine to Sope. Sope, Elaine is asking, how can the social assistance sector, like a food bank, help Black, Indigenous, people of color individuals with informing about mental health options? I don't know if you had any thoughts to share about that.
Yes, thank you for that question. First of all, when we talk about awareness and spreading awareness in our communities, these are some of the places that we want officials and people who work in mental health sectors to be visiting. We want them to be visiting places that are regularly attended, like churches or food banks, to really spread the word and to destigmatize any sorts of mental health issues that may be going on. A lot of people who visit food banks are also looking for that sort of support and could be looking for wider support as well. And so if food banks have, these services, these therapists, counselors, their numbers, all these sorts of resources at hand, ready to kind of share the information, present that to people who are maybe visiting, that would be like probably the biggest and best step in probably like really destigmatizing, because we want people to be able to have access as much as possible, for people to not be struggling to look for those resources, for those resources to be incredibly visible.
Yeah, absolutely. Thank you. Thank you so much, Sope. I have another question for Wency. Wency, one of the things that you mentioned in your talk is sort of how loneliness, one of the side effects of loneliness is sort of the rapid decline of people with dementia as a result of social isolation, not having someone to care for them and not having sort of that social interaction to sort of keep their mind, I guess, healthy. And it's particularly alarming. And this is one of those things that could be kind of irreversible even when the pandemic is long over. And so I'm wondering if you have any sort of insight on how healthcare workers and family members of those with dementia have tried to address this issue over the course of last year.
Sure. Yeah, it's a really challenging one. Because for a long time, and still in some institutions, family members are not able to actually get in and be at their loved ones' bedsides. So there are some kind of sort of pilot projects that are underway that kind of use the virtual tools that are available to kind of help at least keep long-term care residents, for example, to keep them stimulated and keep them, still connected to their families. But yeah, I mean, it's really important for long-term care residents to have at least somebody to come in. One of the sort of experiments that is happening is in Vancouver. There's one home is using sort of pre-recorded videos for individuals with dementia, but pre-recorded videos of their families speaking to them. And that actually has been shown to actually be more effective than live, live sort of FaceTiming. Just kind of they can replay it whenever they want to, and just having that familiar voice and that familiar face seems to help.
That's really interesting. I didn't hear about that before. Thank you so much, Wency, for sharing that. One of the audience members, Shreya, has a question for Dr. Lozano. The question is, in treatment-resistant depression, is there any understanding of how comorbid neurodivergent conditions like autism, for example, that are often underdiagnosed in adults impact whether DPS is appropriate or effective as treatment?
Yeah, I think we should emphasize that depression is really a disorder of the brain and is a malfunction in the brain. And it's very much like having diabetes and you have, your blood sugar is too high. Here, we have areas of the brain that are overactive. And it can be because you're born that way or the environment is driving that circumstance. But I think it helps to destigmatize depression, that it's really a physical illness that can come and go and has a cycle. Of course, there are comorbid disorders, and depression can be part of other disorders. And furthermore, if you have any other illness, for example, a heart attack, if you're depressed, your tendency to die is much higher. So depression is a serious condition leading to death and suicide. But also, if you have any other chronic condition or a heart attack or kidney disease and so on, if you're depressed, you don't live as long. And so it adds to the morbidity of all medical conditions in addition.
Absolutely. Yeah. Thank you so much, Dr. Lozano. Sope, I had a question for you from the audience as well, from Yelini. Yelini is asking, how do you find the balance between taking care of yourself and supporting your family member when you also deal with mental health challenges, especially in Black, Indigenous, people of color populations, where the focus is on the collective family culturally?
Thank you for that question. When it comes to being there for yourself, being there for those around you, there's a lot that can come into play. And one of the things that I take great pride in is understanding boundaries and creating safe boundaries for yourself and for others around you. Because just like when on the plane, they say you have to be able to put your mask on before you can help someone else put their oxygen mask on. You need to be able to care for yourself before you can care for those around you safely. A lot of BIPOC communities emphasize very community-wide support and a collective, which, you know, we take great pride in working with each other, things like that. But it's also important to be able to take that time to care for yourself and create those boundaries. Because if you're not able to do that, oftentimes you end up neglecting both sides, and that can be harmful on its own. And when you want to be building a community, building the strength within a community, you want your own individual self to be as strong as can be for your community as well.
Yeah, absolutely. It's important that we're healthy so that other people around us can be healthy, and we're able to take care of each other that way. Thanks for that, Sope. I do have a question from Mark as well, from Kathy, who's also an audience member. So Kathy's asking if you could give us some concrete tips on how to avoid cognitive rigidity, if you had any thoughts.
Wonderful question. You know, I've experienced it myself so many times, but I've seen it working as a clinician too, where the more afraid you become, the sadder you become, the more difficult things become in your mind, the more you close down the more you focus in. It's almost this evolutionary imperative to wall yourself off and protect yourself. You don't want to open yourself up to the risk of potentially getting hurt, for example, in social interactions, because you already feel so much pain. So of course you protect yourself in that way. So I think the first step is noticing what you're doing, that if you're, for example, becoming more irritable, you find yourself disagreeing a lot more than usual with people. I'm a bit of a contrarian myself anyway, so that, you know, having an understanding of your baseline helps. But recognizing if you just don't seem like you, according to the you that you know yourself as. So that's the first step, is noticing. And then pushing yourself to actually respond differently, to take a beat. That's one of my favorite concepts from humanistic psychology and mindfulness and many others, is that you can create a wider space between stimulus and response. That when something happens, an emotion, a thought, an event in the world, you don't have to go with your very first instinct, your very first thought or feeling. Thoughts and feelings are important, but they're data points. They're not necessarily facts. So when we widen the space, even just for a couple of seconds, it can allow our mind to relax into that a little bit more, rather than just bouncing off the bricks that we've already put around our perception. That's the way that I practice it myself, is to give space for wider thinking, but then also continuing to challenge myself to think differently as well, to ask myself that question: is this the only way that this particular issue, thought, feeling, situation could be thought of? Rather than falling into the echo chamber, not only in my own head, but in the social circles that I've surrounded myself with. So I think that's it. Noticing, creating some space in yourself, and intentionally exposing yourself to perception broadening experiences.
Yeah, absolutely. Thank you. Those are definitely very concrete steps, and I appreciate your perspective on that. I also have a question for Wency from another audience member, Neil. Neil is asking, how do you deal with depression and social isolation when Zoom fatigue is so prevalent?
Oh, that's a great question. Thanks, Neil. Yeah, it is. Zoom fatigue is a real thing, and there are a lot of people who are suffering from it. Well, you know, I guess there are alternatives. For one thing, people have kind of forgotten just to pick up the phone, and like, I feel like sometimes we automatically go to Zoom when we can just call some, you know, old-fashioned telephone. It's great. The other thing too is, where possible and when it's safe to do so, if you can go out for a walk with somebody, a socially distanced walk, do it. And the other thing is, you know, this pandemic is not going to last forever, but the mental health effects and loneliness are. So, you know, in whatever way you can, you know, when it's possible, meet in person.
Yeah, I mean, I'm a huge fan of telephone calls as well. I could spend hours talking to friends on the phone, old friends, and I find that really helps me as well. And you know, I didn't really used to go on walks that much, but since the pandemic started, it's been my go-to. You know, and I know a lot of people have been, you know, trying new things just to see what works for them, even in the short term, so that they could sort of get through this, and hopefully kind of we can all come together one day when it's safe to do so. Thank you so much, Wency. So I have a question for Sope actually. Sope, one of the things that I was curious about from your perspective is just, you mentioned the mental health stigma that exists within BIPOC communities, and it's certainly something that I've experienced with my family as well. And I know it's difficult sometimes to challenge that stigma. And I wonder, like, how do you approach having these difficult conversations about mental health with your family and community at large? And how would you advise other BIPOC viewers who may be struggling to speak openly about issues related to mental health with their families and loved ones?
Yeah, thank you, Nadine. I think one of the biggest things in understanding why often a lot of BIPOC communities have a hard time discussing about mental health, most times there's not language for mental health in other communities. In my culture, I don't really know the translation for mental health. I don't think it exists really. And so that's often like the root where people are kind of just like, we don't have the language for that, so we don't often discuss. And two, weakness is something in BIPOC communities that there's no space for due to just the ideology and just the place that we've been put due to colonized structures, that we have to be strong. We have to work extremely hard, harder than other people have to work. So we don't have the space to show, you have depression, you're anxious, you'll hear, well, you'll have to get over it because you have lots to do for you to show, yourself in a sea of Europeans or, in a sea of white people. You have to show yourself, you have to prove yourself higher. And I think one of the biggest things that's helped me is simply understanding mental health in general and being able to come together, even with the smallest groups of people, where that will start with your parents, your siblings, having those conversations in themselves, and then start widening once you're able to have those conversations with your parents or the people who are closest to you in your community, where then they're able to understand and you're able to dive into different resources together to kind of open that mindset. Then you can start to broaden out and, with the help of your friends and your family, to really branch out and share with other people. That's how I kind of, it's gone for me. And I talk about that with other people in other communities. Once you start small and you branch out, you'll really see how quickly people are understanding that struggle is not normal. Struggling is not normal. And if you're struggling for so long, you stop realizing that struggling isn't normal and just take it as it is. But once you start explaining that and people start opening their minds, then it really does branch out.
Yeah, absolutely. It really starts with conversation and just, having those conversations, no matter how small, and, it does kind of grow and, ideas sort of branch out from there. Thank you so much, Sope, for your insight. I appreciate it. I have a question from the audience for Dr. Lozano. This is from Gail. Gail is asking, I've heard men die by suicide more often than women. Is it possible just as many men suffer from depression as women? However, they don't seek treatment or deny that they're depressed?
That's an excellent question. Depression affects all genders, all ages, and so on, but it does affect young people, and there's very good evidence that it's more common in women. So it is said that 9%, at any one time, 9% of women are depressed, and 6% of men are depressed. So there's quite clear evidence that indeed it is more common in women. As far as suicide, it's very different in men and women. It varies also from different countries. So for example, Japan and Scandinavia have a very high rate of suicide. Countries near the equator have a low rate of suicide. So we don't understand that exactly why it is. Men tend to choose different ways of committing suicide than women. Women tend to take overdoses. Men often do more violent forms of suicide, jumping off bridges, gunshots. And so the success rate of suicide in men is higher because of the techniques that they use than in women. So it looks like indeed there are important differences based on your gender, where you live, et cetera, that have an impact on your likelihood of getting depression and also your likelihood of suicide.
Right. Yeah. No, thank you so much for your insight. I have a question also from the audience for Mark, actually. This is from Jenny. So Jenny is asking, what advice would you give for someone hoping to support a friend or family member suffering severe depression? What questions should be asked to gauge what someone needs without making them feel obliged to contribute the same energy to your relationship that they might not have a lot of energy for? So I guess how to just be, there for your loved ones if they're suffering.
Love them. It seems incredibly simple, but sometimes I think we fall into this trap because we love people so much of what I call fixer fixation. We want to fix all their problems. We want to take their burden away from them. We just want to help. And that's, I think, a good thing. It shows that we want to help and that we care about them. But sometimes we can become so fixated on the problem that we don't see them for who they really are. We don't see the strengths as often. And this isn't, an indictment of anybody. This is what we all do because we want to help. So I think instead, sometimes some of the most effective ways of helping people who are struggling is doing the stuff that doesn't seem like it's helping at all. Talking to them about things that aren't their illness, talking to them about things that aren't their problems, because I experienced this with my own long-term severe and persistent depression, wherein I felt like everybody was just trying to fix me, like I was a broken down car on the side of the road, and that nobody really wanted to just talk about movies or sports or music. And that was the stuff that was really relationship building. And we see this in counseling relationships too. You're not their counselor, of course, if you're their family member. But most psychotherapies work more or less the same, with a bit of an advantage for cognitive behavioral therapy, probably because it's so standardized. But what seems to be the one of the key mechanisms of action is the clinical fit, the clinical relationship. So that's really the driving force, I think, that breaks down loneliness, that helps people to be truly themselves, that relaxes people out of that rigidity, is that sense of comfort and safety, security, and secure attachment. So I think doing things that help with that is one of the most effective ways we can help people to know that they're loved and supported. Only then, when that person is able to get to the state of change where they feel safe and secure and are willing to take more risks to get help, because getting help, reaching out, is risky. Only then, when they feel supported and loved and connected, is that more likely to then be successful, to take those small steps. So we can then layer in some of the more formal supports after that. But I think that first step is always the relationship building and always going back to basics. How can we better find connections in a way that's helpful and appropriate and accessible to that person?
Yeah, absolutely. Thank you so much. I do have to wrap up because we are at the end of our program today, but I just want to say that, thank you all for your insight. I know that probably a lot of our audience members had something to take away from this conversation, something meaningful that could sort of help them, get through this pandemic and beyond, and help their loved ones as well. Thank you to our speakers. Thank you to the Walrus for organizing this conversation and for giving us the space to do this today. And with that, I'm going to hand it back to Jennifer.
Thank you so much, Nadine Yousif, our moderator tonight, Toronto Star mental health reporter, where you can follow her work. And thanks again to our speakers, Wency Leung, Dr. Andres Lozano, Sope Owoaje, and Mark Henick. We have another mental health discussion in the works. It's an article club. So think book club, but for busy people. And this is going to be around Lisa Whittington Hill's recent viral piece in the Walrus, OCD is Not a Joke. And we've asked Mark Henick to join her, along with journalist Anna Meller-Paperney. It will be on our Facebook page, so please follow us there. Just go to facebook.com, type in the Walrus, and you'll get more details once it's posted. Also, keep an eye on your inbox. You will receive a follow-up email to this event. And if you don't want to miss events like this in the future, the best way to stay in touch with the Walrus is to join our newsletter, and you need to opt in. So directions in the follow-up email. At the Walrus, we believe that trustworthy journalism is an essential service. And with your support, we can continue to provide fact-based, fact-checked, long-form journalism that Canadians can rely on, especially right now in the pandemic. So if you enjoyed tonight's event, which was free, please consider making a donation at thewalrus.ca. Click on donate. All gifts, $20 or more, receive a tax receipt. Thank you to Viviane Poupon, Katie Shingler, and everyone at Brain Canada for making tonight's conversation possible. Thank you to our annual sponsors, Inspire, Labatt Breweries of Canada, Air Canada, and Shaw. Community is really important in these COVID times, as we discussed tonight, especially with mental health, even when some of us have Zoom fatigue. So thank you for joining us. Each one of you is part of the Walrus. Merci, miigwech. Thank you. Have a good evening.